Welcome back to the second part of our masterclass. We will now apply the theoretical foundations established in our first session to the clinical bedside. We'll move from signs and symptoms to the scientific markers that allow us to define, diagnose, and manage kidney disease with the precision required for modern practice. We'll begin with a classic and frequent clinical scenario, the patient presenting with bilateral leg swelling. Our goal today is to bridge the gap between the patient's physical presentation and the laboratory's biochemical revelation. This transition from sign to science is the hallmark of a master clinical reasoner. Let's start by examining how we approach the diagnosis of edema in a medically complex patient without falling into the common traps of premature closure or anchoring bias. We must stay broad before we narrow. Meet our 62-year-old male patient. He presents with a 2-week history of progressive bilateral lower limb swelling. Your immediate System 1 intuition might jump straight to a renal diagnosis, perhaps nephrotic syndrome, but as master reasoners, we must slow down. This physical sign is the beginning of our diagnostic story, not the end. We must now apply our structured logical framework to determine the true underlying cause of this edema. We must look for other clues, jaundice, shortness of breath, or medication changes that might point us toward a different organ system entirely. Physical presentation is our first data point. Our mental problem representation must remain exceptionally broad. Using this differential framework, we must look beyond the kidneys. Consider the cardiovascular system. Does the patient have shortness of breath or orthopnea? Check the hepatic system for signs of cirrhosis or easy bruising. And critically, you must review the medication list. Drugs like amlodipine or glitazones are common, often overlooked culprits for dependent edema. This deliberate differential diagnosis prevents anchoring bias and ensures you don't miss a non-renal etiology. We anchor our initial reasoning in probability, but we search with a clinical curiosity that considers every organ system. This systematic approach is how you avoid diagnostic error and provide comprehensive care. We must consider the whole patient, not just the swollen limbs. Our physical examination tools have their distinct limitations, especially in the complex renal patient. Traditional markers of extracellular fluid volume can often be misleading. Skin turgor, for instance, is notoriously unreliable in the elderly due to natural changes in skin elasticity over time. Moistness of the mucosa can be deceptive in patients who are mouth breathers. Even the classic sign of pedal edema must be interpreted with caution. As we've seen, it can be caused by systemic issues like hypothyroidism rather than simple fluid overload. This is why we emphasize that labs and urine are not just extra tests. They are vital biochemical extensions of your physical examination. They provide the evidence that our eyes and hands simply cannot reach. By using these extensions, we build a much more accurate and logical picture of the patient's internal physiology. Now, let's turn to our most powerful extension, the uroscopy. Uroscopy, the detailed inspection of urine, is often the cheapest renal biopsy you will ever perform. The kidney is constantly communicating with us visually. Consider the colors. Red-brown urine might be hematuria, but you must also consider pigmenturia from dietary sources like dragon fruit or the presence of muscle breakdown products in myoglobinuria. Green urine can be a signature of a specific UTI caused by Pseudomonas or the use of methylene blue. We move beyond a simple dipstick to understand the underlying pathophysiology of these striking visual clues. Understanding these colors is the foundation of safe and effective practice. Always remember to confirm your suspicions with further microscopic and laboratory diagnostics. The urine color is the first clue in a much deeper diagnostic story that we'll continue to explore in the microscopic phase. We must listen to what the kidney is showing us visually. When we move to microscopy, we are searching for formed elements. While phase contrast microscopy is not routinely in use in every laboratory, it remains an invaluable tool for differentiating the source of hematuria. It allows us to distinguish between dysmorphic RBCs, like acanthocytes, which suggest glomerular bleeding, and isomorphic RBCs, which point to urological sources like stones or malignancy. However, there are caveats. This rule is not absolute and requires expert interpretation. Use these microscopic clues to narrow your differential, but always interpret them within the broader context of the patient's clinical story. Understanding the site of the bleeding is a critical branch point in your diagnostic reasoning. It tells you whether to look at the nephron or the bladder. This precision is what makes a master diagnostician. We must be careful not to overinterpret any single element without clinical correlation. To define kidney function accurately, we must understand our markers. Creatinine is our most common tool, but it's influenced by muscle mass and diet. Cystatin C provides a more accurate measure as it's produced at a constant rate by all nucleated cells. Beyond function, we rely on definitive blood investigations to establish etiology. Markers like C3 and C4 point to lupus or immune complex diseases, while ANA and ANCA are critical for diagnosing autoimmune conditions and vasculitis. These tests answer specific questions about the underlying cause of the kidney injury. Proteinuria and albuminuria further help us prognosticate the risk of progression. Together, these markers build a complete biochemical map of the patient's disease. Once we have this map, we turn to imaging to visualize the structural landscape. Each marker is a piece of the puzzle that we must assemble carefully to reach the final diagnosis. This concludes our masterclass on renal clinical reasoning. We've moved from the psychological barriers of nephrophobia to the technical precision of modern uroscopy and functional biomarkers. Remember, renal medicine is not about memorizing abstract numbers. It is about structured thinking under uncertainty. If you take a careful history, generate thoughtful differentials, and use your laboratory and imaging tools intelligently, you are already practicing safe and high-quality nephrology. This framework will protect both you and your patients from diagnostic error. Thank you for your commitment to excellence today. Go forth and apply these tools on the wards to save lives. Farewell, and good luck with your clinical journey. We look forward to your future contributions to this vital field.